Thank you, Dr. Narula. And it's my job to keep us on time, so I'm going to go right into this and really appreciate the fact that the hybrid conferences truly extend our ability to get the information out to everyone. I have no disclosures related to this presentation. This is a view of Times Square on a normal day in 2019 and early 2020, and this is Times Square on March 20th, 2020. At the time when hospitals were being overwhelmed. And I think that it's very important for a group of cardiologists who are going to be leaders in your organizations and called upon to deal with everything from critical care to other aspects of the management of this disease to understand how to follow the trends. This is the Mount Sinai Hospital trend, so it reflects what's going on in the New York region, different than what's going on in other regions of the nation, but the principles are generalizable. And so you see here basically 3 waves of decreasing intensity. A first wave that peaked in March, April, and was already waning by May of 2020. A second and slower and longer wave that began in October of 20 and really didn't end until about May of 21. And then finally, an uptick is the way I would describe it, with a very stable pattern, which is an interesting thing to consider in that it may be reflecting both the effect of vaccines and the increased transmissibility of the Delta variant, providing almost conflicting influences upon the pandemic. But one of the things that I think all of us should follow locally is your health system, your regional positivity rates. This is lab tests that are done every day. The bars that are at the top are the total number of tests done. The darker blue bars at the bottom are the positive tests, and then the instantaneous and 7-day moving average of the positivity rate. And what I will put forth to you is you see that the positivity rate is essentially identical to the waves that we see of hospitalization. And this seems to be a leading indicator in that it's usually 1, 2, or even 3 weeks ahead of what's actually happening clinically. So I just encourage everyone to follow the data. We are heart professionals. That's what we do. I'm a cardiac anesthesiologist. We follow the data. In terms of variance, within our region, Delta is basically around 95% of what we see right now. We follow it every week, and I think it's also important to have an idea from your local health authorities what the effects are of local variants, because there are more than, there are more letters in the Greek alphabet than have yet been assigned to COVID, and this is likely to change over time. The Delta variant, though, is so much more contagious than previous strains, probably causes twice as many infections for the given level of people being in closer contact. And unvaccinated people are definitely, probably about 10 times more likely to get severely ill and to require hospitalization and critical care. But vaccinated individuals do have breakthrough infections. They're much less likely to have hospitalization, but I will note that in a tertiary care medical center, you're likely to see a high proportion of vaccinated patients because people with cancer, extreme advanced age, other immunocompromised circumstances are going to be having breakthrough infections, and some of them will be quite severe. So we have to be on top of that. One of the keys, I think, is local public health measures and how we as medical centers deal with that. And instead of widespread vaccination mandates, which are probably sort of on the way and it's in evolution, when our local public health authorities create barriers to entry, let's say in this case to restaurants and to theaters in New York City, that tends to encourage more vaccination, which is good. And so the only point of this slide is that there is not the QR code, which is more for Mount Sinai specifically, but to get vaccinated. And remember that we still have to do the masking in clinical settings, ourselves, our patients, our colleagues, our visitors, because all of this work is happening indoors. And especially if you or the patients are moderately or severely immunocompromised. And of course, no one should be coming to work ill these days. Eye protection is the other thing which I have to emphasize over and over again. We are responsible. We're the leaders in our organizations, and we have to be responsible for communicating, reinforcing good behaviors. And good behaviors at present include, at this time, for every clinician in this audience, whether virtual or in person, that we must be using eye protection for every patient interaction. It's simple enough to do. There are many ways to do it. The very inexpensive coverings are just as effective as the expensive ones. And so also I think it's important, even though we might say as cardiologists, we're not infectious disease specialists, it's very important to be able to be an advocate for appropriate use of monoclonal antibodies. The number of antibody preparations that are currently available and those that are in the approval process are only increasing, including a very promising one that may be more longer acting. Because although there's no doubt that vaccines and vaccine mandates are what are going to get us out of this pandemic, when people have infections, whether breakthrough or primary, if they're at higher risk, we must treat outpatient mild to moderate COVID-19 with these products whenever they're available, and we can get them to people, and this is the key point, within the first 5 days of disease. And also, we finally have an indication for post-exposure prophylaxis. I will note that we're about to start a trial also of hyperimmune globulin, which will be a national NIH-sponsored trial, and I think that's also a very important product to follow over time in addition to the monoclonals. Let's talk for a moment about children. Obviously, children are lagging in the ability to be vaccinated. That will likely change in a short period of time, but it's extremely important that we keep in mind that the children that are in the households are a potential source of infection for older patients who may be more susceptible, and many of our patients with advanced cardiovascular disease will not do well with COVID. And so it's just very important, again, since we'll be called upon as experts, the school mitigation strategies are clearly masking, vaccination, everyone eligible, distancing, disinfection, ventilation, and surveillance testing, just as we should be doing in our health systems. Third doses and booster doses are happening and going very well, and I think that it's important to just follow the science and to encourage everyone to get a booster shot if clinically appropriate. The other thing I wanted to end with in the last few minutes is to talk about COVID stressors. Every single one of us, our lives have been changed. Every single patient that we interact with, their lives have been changed, and the stressors can be looked at in this community phases of disasters, where there's a honeymoon, disillusionment, reconstruction. And as we think about these phases, think about how it affects your staff, the person who manages registration in your practice, the person who is your medical assistant, the people who clean the offices. It's so important that we keep in mind that our workforce has been hurt in a very significant way by the trauma of this event. And so taking advantage of the organizational resources that you have. We're very lucky as a large academic health system with a psychiatrist as dean and a psychiatrist as CEO. We had people at the very top who understood this from the beginning and created these resources. Because we can be as medically correct as we want to be, but if we don't address the psychosocial effects of the pandemic and how it affects us and our practices and our patients, we're not being truly holistic and comprehensive in our care. And so Mount Sinai created something called the Center for Stress, Resilience, and Personal Growth, and I hope that many other organizations that are represented here in the meeting will also consider what you should be doing to support your staff. As I go back to the sort of the final slides here, I wanted to just sort of go back in time and talk a little bit about just how rapidly things were changing in the spring of 2020. We were getting new information, adding new testing, creating new therapies, some of which panned out, like anticoagulation, and some of which didn't pan out, like convalescent plasma. But the point was we were changing things so very, very rapidly. And I think that's one of the teachable moments of the pandemic, is that we can, in the face of crisis, retain our academic vigor, rigor, I should say, but at the same time, focus on what's important. Changing the way hospitals look. These white panels that you see with a hole in the middle are exhaust fans, converting regular patient rooms into isolation rooms. and looking at what we can do. Many people in cardiology are also very much involved in critical care. And innovation to create expansions of ventilator capacity and doing things in surges like having 2 patients in a single ICU room are things that we had to do at that time. But I think the teachable point again is that innovation is acceptable in the face of a crisis, and cardiologists are often leaders in organizations, and it will be very important that they show that leadership. Non-traditional care spaces are things that we all have to keep in mind for surges. On the left, you see tents in Central Park that had patients. On the right, you see lobbies of Mount Sinai that had temporary structures built, some of which, frankly, are still in use today as an express care, urgent care type facility. So ensuring the stable workforce, I think I've gone over this to a certain extent, but I think it's also important to understand that nurses are so stressed by this. And the second bullet point of the team-based care model is the key thing to keep in mind here, is that if you can hit normal ratios, how do you support them? Do we use house staff? Do we use people rotated from outside, like an operating room nurse, to support nurses in medical, surgical, and ICU capacities? And allowing, again, innovation. Here are nurses from our cardiovascular unit who are managing COVID patients, and you see the pumps are outside the room with IV extension. It saved PPE, and frankly, it saved lives because those nurses felt more empowered to be caring for their patients without having risk to themselves. And I can't miss this article published by Dr. Fuster here, showing that at the moment of crisis, science continued. And this is a very early study looking in an observational cohort of patients that were treated with early anticoagulation. And we see that that was associated with decreased progression to intubation and decreased mortality. And the interesting thing is just how acceptable the bleeding rates were considering the effect of anticoagulation. The other thing which is critically important for cardiologists to consider is the fact that the pandemic has really hurt us in terms of preventive care throughout the world. Patients who would normally come for regular evaluations, people who are having symptoms that would normally have a stress test. I don't think I need to tell you all the examples. People are afraid and they stopped coming for their routine medical care, and we are certainly seeing in many cases, especially in oncology, exacerbations of disease based upon failure of patients and practitioners to create continuity in these screening programs. And cardiovascular screening, cardiovascular evaluation is probably very much in the same boat, although I haven't seen literature to that effect. I think following your clinical outcomes locally is very important. Mount Sinai sees the same thing that has been reported in the literature, that mortality seems to be correlated with local transmission rates. All right, finally, what makes us great is that we focus as physicians on science at the same time that we focus on clinical care. And I advocate that every organization should be participating in every possible clinical trial that they can manage locally, because when we offer our patients the latest in trials and we use their scientific resources in our organizations, many of which, again, are related to the cardiovascular programs, we can do better. In terms of personal reflections, I think that it's important to keep in mind that everything changes every few weeks with COVID. And so what we think we know today is different than what we know in 2 or 3 weeks from now. The protocols change, the vaccination mandates change, the variants change, and I think to maintain a focus on clinical and basic science is our best true north, our guiding post. Embracing and investing in research even at the most challenging times, and leveraging the spirit of our academic institutions to create new structures that break down barriers and solidify the collaborations that create great science and accelerate discoveries. So let me end by thanking you and everyone who's participated, who's saved lives, who has reassured people, who have encouraged people to get vaccinated. we all are in this together. And even if we are subspecialists, me, a cardiac anesthesiologist, you as cardiologists, we all have had to change the way we've approached things and to think more in a public health context. And so I encourage everyone to be leaders in your organizations. Thank you so much, and I appreciate your allowing me to give the opening presentation.